before. Probably remember it, so this might be a little boring. Hopefully it's pretty easy because you've done it before. So when we set up parameters on the vent, and we talked a little bit last time about some of the basic functions, and you learned about what a trigger is and what a variable is, right? Triggers and cycling variables, what starts the breath and what ends it, right? So each of our modes do some very basic stuff. So what you can set depends on the mode that you're in, okay? So we cover modes. We're actually going to get to them next week where you'll learn about the individual language of them and what vents have what. But each mode has certain parameters that you set. So if we are in a volume control mode, which simply states that is how the breath is being delivered to the patient, okay? How are we delivering it? Volume controlled mode means we have a set tidal volume with a variable pressure. Okay, because each breath is going to take a tiny little bit of a different pressure to get that breath delivered. So I can set Kiara at a tidal volume of 400 mLs, and the ventilator is going to say, okay, she's this young, she's this much of a female, here's her ideal body weight. It should take this much pressure to get that breath into her in a certain timing mechanism, so by eye time, okay? But let's say she's getting a little sicker and her lungs are becoming more stiff, she's losing compliance. So the next few breaths might take a little more pressure to get the job done. Still same tidal volume delivered, but pressure can vary. Make sense? Okay. If you're in a pressure control mode, controlled mode means that breath is being delivered by a set driving pressure. We refer to that, as you've probably seen this in the hospital already, like that, a delta P. Okay? So that driving pressure is referred to as a delta P or a change in pressure, and that is what this little sign means. That's all it means. Mm-hmm. Did you have a light bulb moment?
No, I just had a memory back in high school chemistry.
Ah, also true. Okay, so my driving system or my control modes are either going to be a volume or a pressure control. All modes work this way. I'm either setting a volume or I'm setting a pressure. Those are the two choices I have, okay? What I want you to know is if the volume control mode is set, the tidal volume is going to be guaranteed, but the pressure is going to vary to do it. Pressure control mode, I'm setting a actual pressure that is a limit that I'm going to have. The patient can't go past it, so the tidal volume can vary a lot. So what I mean by that is, I'm setting that limit, so the patient can't exceed 20 centimeters, but they could take a perfectly huge breath, they could take a half a breath, they could take a wimpy breath, they could bounce all over the mouth, and so tidal volume can vary quite a bit, okay? Whereas if I'm doing a tidal volume that I'm delivering, centimeters of water if you can't read my chicken scratches. Okay, so the volume's being delivered, it may take more pressure to do it. Does that make sense, everybody? Okay. So why do I care about this? Well, because my peak pressure is climbing after I get to a certain limit, and remember the word for limit is alarm, right? If I set a safety, or I'm going to say, I'm not going to let you go past 25 centimeters of water, what's going to happen is all of my tidal volume actually does not get delivered. This part gets cut off. Does that make sense? So the ventilator will not deliver the tidal line that it's set if you have your peak pressure alarm set below where your driving pressure is at. Does that make sense? This will be really evident tomorrow. I'm going to show you what it looks like on a vent. But a lot of people get confused by this because they think, well, a limit is what allows the breath to end. Not really. A limit is what stops inspiration from happening. If I'm not able to get my whole breath, it's because I hit that limit, okay? So cycling variable, limits, and a trigger variable. So trigger is what starts the breath. So if it's a rate set breath, it is a time trigger. I'm gonna give you so many breaths a minute, no matter what happens, you're getting at least that many, right?
Is it gonna do that as soon as the patient hits that? Okay.
Yeah, so it'll dump the pressure. And like I said, I'm gonna illustrate this for you on the servo tomorrow because it's really easy to do on the servo. You can make it dump pressure pretty easy. Now, I'm going to all this explanation to tell you this because if I have a really long eye time, right? So if you're looking at my breath, this is my eye time, okay? If I have a really extensively long eye time, I can actually screw up the amount of the breath the patient's getting. So I have to be careful with that. Normal eye time is about 1 second, right? We talked about this before. So the normal eye time with the range being somewhere around 0.8 to 1.3. We have used 1.5 before, okay? And on a very rare circumstance, we do inverse IDE, where I want you breathing in a heck of a lot longer than I'm gonna have you breathe out. We'll get to that, okay? So normal IDE is about a second. I don't want it to be too short, right? Because if I do something stupid with my timing mechanism, well now I only have, they only give you a 0.5 second eye time. They only have half of this breath. It's not even enough time to deliver the tidal volume. And the vent will try to compensate by shoving way more pressure at you to make it happen faster. Does that make sense? So timing for eye time is very important. You have to breathe in, you also have to breathe out. So that's where our I to E ratio comes into play, okay? So our ratio I need to let somebody breathe out longer than they breathe in. It's extensively important. You guys all know, you've seen probably a patient air trap by now where they've taken a breath and they can't exhale it. They take in another breath, they can't exhale it. Pretty soon, they're just, and nothing good's happening, right? Because they can't exhale. So no matter what you do, you have to let the patient exhale. E time, okay? Remember, our total cycle time is just how long the I time and the E time take to happen. In difference to the ratio, this is the ratio. I time and E time are physical measurements, right? Remember this from before. We got all into this in IPPB, but it's been a moment since you thought about it, right? You didn't really care about it then either, did you?
What is ideal?
Huh?
1-3.
What's that?
What is ideal?
For a ratio? Yeah. Anything, I mean, 1 to 2 is the minimum you need. I mean, it depends on your rate. So let's say we're doing 60 times 10. So my total cycle time is 6 seconds, right? So if 1 second is my I time, that means I have 5 seconds to exhale. That's pretty good. That's pretty good. But as I increase my rate, right? Say my I time, 1 second. Then I get a little less E time. Still okay. But as the person starts to help out more, so let's say they're not breathing at just 15, they're breathing at 40. Or they're breathing at, you deliberately have them set at 34 because you're trying to blow down their CO2 because they have COVID from hell. What's happening to my timing mechanism? It's going to get all kinds of stupid, isn't it? And as the patients start to breathe faster, I time becomes more important. So the faster the person needs to breathe, the shorter the I time has to be, right? I got to get it done quicker. If you're going to force me to breathe on a ventilator at a rate of over 30, you better drug my butt. I'm telling you now, I'm going to come back and haunt all of you. What I see at levels that really bothers me is we have all these people set on rates of 34 who are barely sedated. So trying to overbreathe. So I have my ventilator 34, They're trying to add 6 more to that. They're breathing 40 times a minute. How is my IE timing window going to fit in there? We have all kinds of stacking. We're also causing pneumos. Barotrauma. We're going to get to that. Okay? Not good. So all of this also is related to our compliance, right? If you're nice and compliant and stretchy, normal compliance in a normal healthy person who's not intubated is way up over 140. Nice compliant lungs, right? Ventilated people are a little bit less. They run around 100 or so. We'll get to the actual details in a later topics, and I'll worry about all that. But the more compliant I am, the resistance has to be low, right? They're inversely related. If my resistance is in the ceiling, my compliance has to be crap. Well, now I'm breathing 40 times a minute with very stiff, awful lungs. What's that going to feel like from a patient perspective? Right? It would be like you occluding your nose and you breathing through literally a McDonald's straw. Got stuff down your throat, cuff inflated, your hands are tied, perfectly awake, and you're trying to deal with that. It's horrifying. And what I'm seeing at Loveless is all these people who are doing the de-escalated COVID, which I think is a horrible phrase. De-escalated COVID makes no sense. They call it de-escalated because it's been more than 3 weeks and they've had their course of treatment. So therefore they're not infectious anymore. That does not mean they don't have it. Their lungs are still hamburger. How many AMJ people have you seen that are still trashed even though it's been a month since they got it? Mm-hmm. De-escalated is a stupid word. I don't like it. It's not a good term at all. So we have to look at our settings, what it's going to do to the patient, and how we have to interact with things like compliance, lost volume, which we're going to get to. We have 2 compliance formulas, and today we're going to work in lost volume, and our resistance. Resistance is work to overcome. We have to work hard to get that breath to go in. Like I said, if my compliance is starting to turn to crap, I'm going to have to go up on the pressure to get it done, and the ventilator does that automatically within reason. So if I set a limit, it will dump that extra volume. So you actually can detour or change the tidal volume the patient gets simply by lowering your alarm. That's all you gotta do, and I'll demonstrate that for you tomorrow. People don't understand that. They're like, wait a minute, the guy was okay, and then something changed, and now I'm losing half my volume. Well, because your peak pressures now have jumped over where you had your alarm set, and it will not deliver the volume. That stops inspiration. Okay? Are you clear on limits versus a cycling variable? Okay? Not the same. So we have what we set, and every one of our modes has different parameters like tidal volume, rate, FiO2, PEEP. There's all kinds of good stuff we can set, and we're going to get to the individual modes next week. But the ventilator also tells us what the patient's physically doing. So if I set for Kiara 400 ml tidal volume, and her lungs are pretty compliant, I better get back 400 ml as exhale breath, right? I've got my drive line into the patient, my pneumatic circuit, in and out. I should get it, right? I should get it back. If I don't, something's wrong. Either it wasn't delivered in the first place, or there's a leak somewhere. Maybe her cuff's not inflated. Maybe the MDI port on your circuit's open. Perhaps your temperature probe is leaking. Who knows? It's leaking from somewhere. Could be a chest tube. Okay? I need to figure it out, because if I'm trying to ventilate her and I have to get back past anatomical dead space, right? Anatomical dead space for most humans in the 5.5 to 5.8 range is about 150 mLs. If I'm only getting 250 to her, I'm only getting her 100 ml tidal volume per breath. Does that make sense? So that all has to be taken into consideration. So they should be the same. If they're not, you need to figure out why. Sorry, this room was frozen this morning, and now it's too hot. Okay, so by now you guys all know how to do the calculation for ideal body weight, right? If you forgot, it's right here. So it's 50 kilos plus 2 times the inches over 60, okay? So if you were going to do it precisely right, you would want to use 2.2 kilos. This is a perfectly reasonable hack for the board exam. You don't do a whole bunch of math. Plus, you only have about 1.5 minutes per question, so if you have to calculate somebody's initial vent settings, I'm not going to be spending all kinds of time trying to do this. Don't care. 2 will get me close enough, okay? Here's an example if you forgot how. So we have a patient who's 61 inches tall. So I'm going to put the first 50 kilos plus 2 times 1, because I just have 1 inch over 60. This 50 kilos accounts for the first 60 inches. 1 inch times 2, I have 52 kilos ideal body weight. How many humans around this country are perfectly ideal body weight? You probably can count them on your fingers and toes. No, I'm kidding, but there's not that many people who are running around at perfect ideal body weight. So we do this calculation. Any questions about this? So we learned before, and you probably forgot now because it's been a minute, but when we did IPBB, we were trying to target a specific breath, right? We wanted that big breath. They were being forced to take a big deep breath in order to open up their lungs and to treat known atelectasis. Remember that? That's a test question that one of the seniors just saw on their practice boards. Okay. Now for spontaneous tidal breathing or spontaneous breathing, as you guys sit here, you're doing roughly 5 to 8 mLs per kilo. Well, now let's talk about mechanical ventilation. Okay, so mechanical ventilation range, and I'll just write it up here. Now, before your head explodes, this is what Kettering recommends. Who's going to do your review example? I'm telling you this so you can put it in your notes. Dr. O very specifically wants me to teach you this because that is what he knows to be current on the boards today. I'm trying not to confuse you. Now the reason this is nicer is because this is really easy math, right? If I have somebody who's 52 kilos, I multiply it by 10, I have a high side of 520. I just half it. I figured out my range for tidal volume. As opposed to 52 kilos times 8, and then 52 kilos times 6, I'm going to get a very, much less nicer math. Does that make sense? You do notice the theme here though, right? I have 8, and I have 8 in the middle of that. So 8's pretty good. So as a hack, on a board exam, if I use 8 mLs per kilo, it's going to get me right in the range of where I need to live. Okay, does that make sense? Everybody still with me? So Kettering is going to talk about the 5 to 10. Math works out much nicer. And as you guys start to practice some of this math, do a couple where you're doing it this way for what the boards want from you from Dr. O. And do a couple this way. It's not that different. It's not that different. Like you're not going to have such dramatic tidal volume changes that it'll screw you up. Does that make sense? And I don't want to confuse you, but this is what Kettering's going to tell you because I just listened to it when they did it through the last series. So that's that. Now, while I'm writing all this down, let's talk about a couple others. Okay, 4 to 6 ml per kilo if you're RD or you have COVID. We are deliberately ventilating people with lower than normal tidal volumes to protect the lungs. Okay, so somebody who's in status asthmaticus is going to get 4 mLs per kilo. COVID and ARDS patients are doing 4 to 6. So you walk into my COVID unit and see a lot of adult men with tidal volumes of like 250, 350. Because we're trying to go out, and you've seen it, right? Okay, and you're like, well, geez, I'm not ventilating anything, but the bigger we go, if we use this, I'm gonna be popping all kinds of lungs. And even with these dinky little stupid tidal volumes, we pop lungs with COVID because lungs are just so destroyed. So somewhere in your notes, put it even on your Whoopie. It would be a great place for this to keep it all together. Put what's spontaneous, what's IVBB, what's mechanical tidal volume, asthma, and COVID ARDS. Get those all in one place. Because one of the things I have to figure out, besides picking what mode I want for you, is what's the tidal volume I'm targeting. Because in volume control, I set the tidal volume. If I'm in a pressure controlled mode, I don't get to set the volume, I set a driving pressure. And with that, I'm targeting the volume that I think you need. Make sense? Pressure control is a nicer mode from a patient perspective, and you guys will get to experience this week. Like I said, I'm going to load brand new circuits on all events. You'll have a new filter. You can get on there all you want to. Change the modes on each other, see what they feel like. From a patient perspective, if it's not a spontaneous pressure support mode, pressure control is the next nicest. Any questions? Okay, good.
A lot of these parameters, would they be the same as BiPAP or?
We target also with BiPAP certain size of breath, but we don't really do a lot of math for it. What you're trying to do is target the ventilation that you're trying to correct. We actually have a whole lecture coming up on non-invasive ventilation. We're going to cover that. We're going to go back to all those blood gases and how you correct it with both non-invasive and also with the ventilator. We have lots of that coming up. Okay. So if you forgot all that, here it is. Or you didn't write it down. So tidal volume, by definition, is the amount of volume inhaled or exhaled in one, well, inhaled and exhaled actually, in one breath. Okay, there's the normal values again, based on ideal body weight. So tidal volume is also, you can obtain it by getting the flow, the peak flow on the machine, times the I time. So you have some formulas coming up again. Tidal volume affects ventilation. There's two things that affect minute ventilation. You probably remember this formula. Okay, with minute ventilation being described now like that. A V and a dot with an E. That's minute ventilation.
I had a question.
Yeah.
So for the mandatory minute ventilation, is that the same as the minute ventilation, or is that a different?
So it's a different mode. So I'm guaranteeing your minute ventilation by setting a tidal volume minute rate for you in a standard mode. They do have a mode called mandatory minute ventilation where I'm targeting a minute ventilation that I want you to have, and pressure support will be increased or decreased in order to make your tidal volume fit that profile. Does that make sense? We're going to get to that. Okay. So I can flip this a couple ways, can I? Right? If I want to know what that is, I can do. Okay. Or if I know what this is. So I can flip that. Okay, remember though, when we're talking about tidal volume, it's always going to be in mLs. Don't screw that up, it'll be all messed up. I will never have a minute volume of 15,000. Okay? So if normal minute volume is somewhere around 6 liters per minute, give or take, I shouldn't have 6,000. Okay, so that just means your decimals are winding up in the wrong place. So we can find tidal volume in a bunch of different ways. I can target it using this. I also can see what they're getting by taking their flow times their I time, what they have listed. Exhale tidal volume is what's returned to the vent. So I push the breath into you, it comes back. Should be pretty close to what I pushed in there. And you guys have seen this now. You've looked at a couple of people on vents, right? Where you're running a tidal volume, you're getting back something close to that. So our rate is what we set. Some ventilators describe it as an F for frequency, or R for rate, excuse me. We typically breathe about 12 to 20 times a minute, but we start the initial ventilator rate between 10 to 20. So we're spontaneously sitting here, you're doing 12 to 20, okay? On the vent, I can start with 10. That's one breath every 6 seconds. Huh?
Why start with 10 instead of 12? Is that just easier math, or?
No, it's just the way that, so if you're breathing by yourself, that's just what normal people do when they tracked a whole bunch of normal people. But this is where we're going to start off when I do mechanical ventilation on you. Okay. Rate and tidal volume influence minute ventilation. Hello, hence the formula. Okay. We can calculate what the rate is by doing 60 divided by total cycle time. Okay, so if I want to figure out what the rate is, okay, so I can flip that too. Okay, if you have any 2 or 3 variables, you can get the other. Okay. Our minute volume, you'll see it a couple different ways. A V, I could make it do a dot, but a V with a dot, tidal volume times rate, just put it there. Or exhaled, you could do frequency times tidal volume if you want to, same thing. Or RR times VT. So depending on what book you get into, these are all the same. Okay? For my class, we're gonna use that one. They all mean the same stuff. Normal minute volume is typically around 5 to 8 liters a minute. 5 to 8 liters a minute. Now, are people who are acutely ill, suffering from COVID, breathing anywhere near normal minute ventilation?
No.
Of course not. Their work of breathing is huge, right? So they're definitely breathing more. They're breathing faster, they're breathing deeper, they're air hungry, their work of breathing goes up.
That was 5 to 8 or 6 to 8?
5 to 8. Now, as you guys know, because you've done some, what do you call it, mini clinics for Miss Polly, she asked you to calculate a bunch of stuff, right? So one of which you either need to calculate or you need to physically find it on the ventilator is the flow. Okay, so the formula for flow is tidal volume in liters divided by I time in seconds. You get a funky little decimal, and you multiply that by 60 to get liters per second. So this is it right here. Flow can be listed as liters per second or liters per minute. Okay? So if you're told that the patient has a flow of 40 liters per minute, that's fine. But if you have to find it, I have to multiply it by 60 to get it to make sense. Okay? So normal flow is between 30 and 60 liters per minute. And 60 liters per minute for flow. Now, the crazy part is that these ventilators who are so smart can jack you clear up to almost double that. So if you are really air hungry and you want to suck in an enormously big breath, you have the power to do that, okay? Depending on the vent and how you can set it. So a piece of the puzzle to how quickly our breath is delivered is our I time, but also flow. So if I want flow to be faster, I shorten the I time, okay? If I have less time to get there, I gotta go quicker. Make sense? Okay. It's like driving to Santa Fe at 95 miles an hour and at 45 miles.
So you said shorten I time to increase
Flow, yeah. Because if I need to get there quicker, I gotta go faster. Make sense? Okay. So if you wanted to, these are some practice ones. We're not going to do these because I have a whole packet for you. You guys are going to sit and practice here in just a little bit as a group, and I'm going to help you just to kind of remind you how to do this math. So again, once you do the flow, you would divide out 0.6 by 1. So you're going to get 0.6, multiply it by 60 to get your flow, which I don't have a calculator. What's real math on that? Those are calculated in front of them. So take 0.6 times 60, should be what, 36 or something, I forget.
It's 36.
36. So this person would have 36 liters per minute of flow. Okay? Pretty easy. Okay, so our I time, we've talked about this before with IPBB. That is the amount of time it takes for you to breathe in. Okay? The more volume you have to get to the patient, whoopsie, the more time you need to get it done. The higher the flow, the smaller the I time. So again, going to Santa Fe at 95 miles an hour, I'm going to get there quicker. Okay? We're trying to keep an I time around 1 second, and of course it's abbreviated IT. Now, as promised, I don't know if you remember this, I said to you when we first learned this stuff, there's actually several ways to skin a cat. And we're going to get I time in a bunch of different ways depending on the data that you have, okay? So I time, this one you've learned, is tidal volume in liters divided by flow in liters per second, and don't forget to convert that first. If it's given to in liters per minute, you just divide it by 60. I also can get the I time by doing something crazy like taking the total cycle time divided by the I plus the E. Okay, so if I have a 1 to 2, I'm going to take the total cycle time divided by 3. Does that make sense? So you're adding up the pieces. Okay? You know this one already. I time equals total cycle time minus E time. This is a new one to you. I time equals total cycle time times the I time as a percentage. So if I had 0.8 as an I time, and a total cycle time of 4 seconds, say my I time is 0.8, okay? I'm gonna make that the decimal. Multiply that out. What do I get? 0.32, 3.2, something like that. What does it come out to? Get the math. Yeah. These are just numbers, they don't make any sense, that's okay. Okay, so the key is just to remember you're doing this as a decimal, so whatever your I time percentage, so say you had, I'm sorry, not I time, but let's say we had a 25%. I'm gonna do that. Now do the math, maybe that'll make more sense. So what is it? 1? 1? Sorry. So you just take whatever the percentage is, make it a decimal, put it in there. Okay? It's like that looks so weird to me, that's why.
So your I time would be given to you in
Yes.
percent?
So you would have an I time percent. Some ventilators, in particular pediatric vents, run an I time as a percentage, not just an I time. We're gonna cover this more later too, okay? But for completion's sake, because we're talking about I time, these are all different ways you can get it, okay?
And then, just, to clarify, so that 4 seconds, that's total cycle time?
Correct,
Okay.
yeah. And that you're gonna be given, or you'd be given the rate, and you could do the total cycle time math, okay? So the boards can give you any 2 of 3 pieces of something, and you should be able to figure out the rest, okay? But they expect you to know that a normal I time is about a second. If you don't remember that, you don't know if you're doing it right or wrong. Does that make sense? Okay. I also can do I time equals E time times the I ratio. So if I had an E time of 3 seconds, oh my gosh, seconds, not X, I was trying to my X too early, times the I ratio over here, which is 1. Okay, you can do it that way as well. We don't do a lot of inverted IDEs, but there's certain times that we do. Okay, so again, you're gonna get to practice all these in just a little bit. Okay, so do you wanna try it now? You can give it a try. So this is the one where we're gonna use, go back a page, we're gonna use this formula right here. Okay? While you're doing this practice math, I want you writing down all the formulas as you go. It'll help you remember them. Okay, so I have a patient who's set at a rate of 20, so I need to figure out total cycle time first. Okay, so I'm gonna look that in up there. IDE ratio is 1 to 4, so that comes out as 5. What's the math? Sorry? Thank you, Cassandra. Which is pretty short, okay? But for math purposes, I just pull numbers out of space, so they're not always gonna make sense with what's a normal I time, it's just for the practice of it, okay? Does that make sense to all of you? Got it? Because these are ones you haven't done before. Good? Okay. Lee, good? Everybody else okay? Make sense? Good?
Yeah, it's good in there.
Got that face like I don't know for sure. Okay. So E time we already know as well. So E time is total cycle time minus the I time. And the E time is how long it takes you to exhale. Exhalation is typically passive, right? But I have to let you exhale longer than you inhale or you're gonna air trap. You don't want that. So we have some formulas. You can do total cycle time minus the I time, which you know. A new one for you is I time times the E ratio, okay? So let's say we had a 1 second I time and a 1:2 ratio, okay? So let's just say I time was 1 second, I to E was 1:2. So very simply, that one's probably the easiest one you'll have. No brainer, very easy. Okay? Now for these practice problems, and on the board and on all my tests, you're going to be given enough data to get to the third piece. Okay? So you just have to ask yourself, what's the question? What data do I have? Does that make sense?
Where do you do 1 times 2?
Not 1 times 2. Oh, 1 second, because that's my I time. My ID ratio is 1:2. So I take the 1 from here and the 2 from here.
So you don't need to worry about the 1 for the inventory?
This is my I time. 1 second. They put it here.
And it's gonna, give you the 1-2 ratio then?
Yeah, so you'll have the I to E rate and then the I time in order to do this. Okay? Like I said, you have to have 2 or the 3 pieces or you can't make the math work. That makes sense? So they're just given to you. You just have to put them in the puzzle. But you see why I taught you a lot of these before? Could you imagine if you had to learn all these today without the ones that you previously knew? It would be horrible. Total cycle time you know as well. That's rate, 60 divided by rate, or I time plus E time, right? Breathe in, you breathe out, they go together, they make 1 cycle. Any questions? Here's math for it if you want to see. So we gave an example of a patient who has an I time of 0.7 seconds and an E time of 2.3 seconds. What is their total cycle time? So the formula I need is total cycle time plus I time plus E, so I just add them up. So I've also seen one that's like this that actually asks you what the rate is, what the respiratory rate is. So if I got this far and I wanted to know what the rate was, I'll just have to do this. And it would tell me. Okay, so just one more step. So sometimes they kind of ask you questions indirectly and ask you to get to the same endpoint. Okay, do you guys remember how to do this? You want to work them through? Huh?
Can we do it?
Yeah, try it. Go and try it. And then go get a quick sip of water and I will be right back and we'll do it. Try it for yourselves. And take a drink already.
What?
Yeah.
Can you imagine if you didn't learn this before? Like, wouldn't that be horrible? Yeah, just
Can you fucking imagine?
That's where we are.
So, does everyone want the recording for this lecture? Because I am recording it. Someone please remind me, because I always forget, but I am getting it.
What did we find first?
Find your total cycle time first.
That's the easiest
So
one.
you have 12 breaths per minute.
I don't like this.
Anybody get that far yet? Huh?
Yes.
What'd you get? This?
Yeah.
Yeah. 1.6? It's like 1.614. 28571, who cares? 1.6. Okay? How do you feel about it?
So I have everything up until the ratio.
Okay. So I time divided by I time, E time divided by I time. Now the reason I want you to write it that way is because pretty soon we're going to talk about inverse ratios and we have to flip the formula. So you need to learn it the correct way so you know when to flip it. Okay? This is always going to write now, Cassandra B1, how we're working it now. But you're going to flip stuff around a little bit though. Okay? So that's why I want you to write it as a 4-part ratio just to keep it straight in your head.
So that's not like ideal, like it won't always be 1.
It's not always going to be that way. Yeah, we do some very specific instances where we inversely ventilate somebody, and we're going to get to that at the end of this class. Not the class today, but as this whole class. Okay?
And
You want to write it down so you remember each piece.
can you show me how you got the 6 too?
Here?
Yes.
Yeah, so 4.3 divided by 0.7. You get 6.142857 so just round it.
Thank you.
Now, you actually can leave this if you want to. Because it's 6.14, you actually can leave it as a 6.1. If you've ever seen the ventilators, they will break it down to in a tenth position. And it actually changes breath by breath. Okay? I'm totally okay with you leaving it at 1 to 6.
Can you explain the I time to me,
Mhm.
please?
So we're doing I time. This has to be in liters. So basically, instead of dividing it out, just put a dot. Because it's in milliliters. So just put a dot. I threw that right here. My flow in liters per second, I have to convert rate my liters per minute first. So I just take whatever it is and divide it by 60. So if it's 30 liters divided by 60, I get 0.5. What is 45? Let's see. Because these are some of the common ones that you're going to see.
It's what, 30 liters?
Yeah, so this one, I'm getting 1, which I put here. But let's say we have 30 liters a minute instead. Take 30 and divide it by 60. Gives you 0.5. So those are the 2 most common that you're going to see for math. So if you hate the math part, just remember those 2. 60 is 1, 30 is a half.
So the total value has to be in liters.
Right. Right. So rather than even divide it out, just put a dot in front of it because you would normally just divide it by 1,000, right? I don't have time for all that. So just put a dot. Also, old school, you learned in kindergarten, 1, 2, 3 positions is where it goes. How we doing? Feel okay? It's coming back a little bit, yeah. I had one class goes, we already learned all this. I said, and do you know it? So I gave them a packet to play with, and they all screwed up. I'm like, you forgot already. Now, the great thing and the super bummer to all this is I don't know how much math you're going to get on your boards. It could be millions of questions. It could be no question. I mean, you just don't know. You just don't know. So you have to know them all. Okay? Now, that being said, you have to know everything just in case. But what I will tell you I'm hearing out of the new board, people who've taken it, is that it's not a whole lot of just can you vomit up the math, but more importantly, what's this formula for? What's the normal value supposed to be? Some of it you will have to calculate. I promise you you'll see compliance and resistance because you always do. But there's not going to be, you just never know what you're going to be asked, so you kind of have to just know it all. Okay. All right, everybody all right with this so far? We're good? Okay. Okay. Here's one with 30. So when you put in the formula, you're going to divide 0.55 by 0.5. That's going to give it to you. You want to try this one? Go ahead, work it out. Work it out and tell me what you find. Guys getting something?
Something.
Something? She's like, I have no idea if it's right. I got something. What'd you get?
Total cycle time, 3.7.
Okay.
I time 1.1. E time 2.6. Ratio 1 to 2.3.
Okay. What'd you guys get?
Same thing.
Same thing? Good. Yeah, that's totally fine. You could even have left the total cycle time at 3.75 and been okay at the end. But as long as I can follow your math, and I know that you didn't make a mistake, you're gonna get your points for it. Okay, so on tomorrow's quiz, when you're doing math for me, if you can list it out for me, then I can see if or where you screwed up and give you some of the points for that, okay?
Like this
Hmm?
and put the 3.75.
Yeah,
That's good.
yeah,
Okay.
absolutely right.
And
Even-
what's the IE ratio?
So she got 1 to 2, what was it?
2.3.
1 to 2.3. I left it at 3.75, so I got 1 to 2.4. Who cares? As long as we're close, okay? But I to E is perfectly okay to leave it 1 to 2 point the first decimal. It's okay, whatever it is there, just leave it that way. Round up or down as accordingly. So the key is just round to the tenths position most of the way and you'll be okay. Like I could have done 3.8 instead, but I would have got something a little bit lower. That's okay. Like I said, on a real ventilator, if you've ever watched it, it changes breath by breath. Every time somebody exhales, it changes, right?
So, but that's what scares me about rounding. Like, where do you round? Because I feel like you just keep rounding.
You're gonna get something weird the
Yeah.
whole way, yeah. So where the I time came out as a 1.1, I would have left it like that, okay? Total cycle time, you got 3.75. I left it that way just for math completion purposes. You would have been fine if you made it 3.8. That would have been okay, all right? Because for example, on my test in particular, I'm not gonna be giving you, 3.75, 3.78, 3.73. You're not gonna get that. It's either gonna be close to it or it'll be so far off you can't guesstimate that that's what it is. Does that make sense? You won't have to wonder about it. The answer will be there in plain view, whether you round or not, okay? But you could have left that at 3.8 if you wanted to, and then you would have 3.8 minus 1.1, you would have got, 2.7 instead. Who cares? Okay, they're pretty close, and as long as I can follow where you're going, it's fine. Okay? Did everybody get that? Or something close to it? Yeah, good. Okay. All right, Now sometimes they ask you to reverse engineer all this. So I have to find, if I have 2 or 3 pieces to a puzzle, I can find the other piece. And I was just looking at the slide, I think it's, something's wrong with it, hang on a second. Okay, so the top part of the slide, you're actually looking for I time, that's the formula you want for it. So you gotta do I time, and you're gonna be using the one that says, no, I don't have it listed here, but I don't. Actually, I don't think you need to do that. Now that I say that, that's very weird. Okay, I'm gonna. Skip number 1 for just a minute, because I'm not sure what it's trying to tell us. This is a slide that I think is messed up. Okay, so we have to find a bunch of parts because we're trying to figure out what the rate is. So I actually have to come up with what the I time is and the E time. So I can add them together to get total cycle time. I'm just looking for total cycle time because that's how I figure out what the rate is, okay? So if you do step 2 here first, it says to get E time, multiply, what am I doing wrong here? Oh yeah, I time, here we go. I time times, your I time is 0.8 seconds, that's given to you. So you have to find the E time, and I'm gonna do that by taking the I time times the E ratio. So in this case, I have an I time, which was 0.8, and I've got E time, which is my second half of this, so that's 6. And that's where I'm gonna get 3.2, I believe. 8 times 6. Oh, 4.8, I lied. So I don't do math in my head. Okay, so your E time is 4.8. Make sense? Okay, and then to find the total cycle time, I just add the 2. And I get a 5.6 second total cycle time. And then to find the rate, which is our last statement here, you just divide 60 by 5.6. And you get a total rate of 10.71, right? I actually have to round that up because I cannot give a part of a breath. So for respiratory rate purpose, I need to make it the whole number. So I need to round up or down as accordingly, okay? This first statement on here, draw a big fat line through it because it doesn't even need to be here. Get rid of number 1. Number 1 is not a part of anything. Okay? I have to delete it, but it's not letting me on here. So once again, this slide, ditch number 1. So I was given the I time, I had to find the E time, I added them up to get the total cycle time, and I took that total cycle time and divided it into 60, which gave me my rate, which was 10.71. I have to change it to 11 to have it make sense. Okay, and it's all up there on the board. Does it make sense to you guys? Okay. Statement number 1 is stupid. It does not need to be there. One of the other things that we typically set is our fraction of inspired oxygen, okay? And there are a couple of rules for this, and again, we're gonna cover this more next week. We wanna keep the patient, we wanna improve oxygenation, right? But we wanna keep them safe. So remember, there's something called O2 toxicity, and especially when you're talking about our chronic obstructed friends, they cannot have a lot of FiO2. We don't want them any higher than about 32% FiO2, that's not even, that's 3 liters, right? We don't want them to have a lot of oxygen. Unless it's an emergency, in which case if you're dying, pulmonary embolus, you're in a fire, you get 100%. If you arrested, we're already giving you 100% with a bag valve mask, you go on the vent, you get 100%. Okay, so there's some rules to it. So complications, O2 toxicity, nitrogen washout, and surfactant depletion. So you deplete the surfactant, everything else goes wrong.
Bless you.
Which is not to say I don't want to walk in and give you 100% for a few minutes because you need it. I just don't want to ventilate you like that for hours and hours and days, if I can help it. Oxygen is a drug, right? The longer you're on a drug, the more potential side effects you have. Okay? So our rule for this, for the board, remember this rule? Okay. Now, from a beginning ventilator situation, okay, so if we have them already on a vent or they're going on a vent, okay? So if we're transitioning them, they're getting sicker, we're going up on their FiO2, I can take that clear to 60%, and then I have to add or increase my CPAP, PEEP, or EPAP. Remember, those are cousins who work on the same lung group, right? They do the same job, okay? Now, if you're setting up a new vent and you don't know what the person was on, you can start between 40 and 60%. Or you can match what they were on. So if I already had Leah at 50% on another device, I could put her on the vent and match it at 50%. Does that make sense? Now, if you're dying though, you get 100%. I don't care who you are. I don't care if you're COPD or not. If you're dying, you get 100%. Because that's an emergency. All emergencies by 100%. Okay? We're going to talk about this more next week when we get into specific modes and what we set for each mode. Okay? We want to keep the people on the least amount of oxygen that we can do safely that'll keep them healthy. And keep their sets where we want them. Any questions about that?
So, and I guess I'm just a bit confused on what that second sentence
Mhm.
sentence means. Are you saying if the vent settings are unknown?
So for the vent, when I start the vent, okay, so start a new vent, I'm going to intubate you. What FiO2 did I pick to begin with? Okay, so if I knew what you're already on, I could match it. If you were on room air previously, or I didn't know because I walked into an emergency, or something weird happened, and maybe you were on 2 liters before, but we have to ventilate you now because you went to surgery. If you're on 40% when you come out, I'm going to match that. If I don't have a clue what you were on before, I can go between 40 and 60%. These are just for initial vent settings, okay? But if I knew you were already on 50%, like the example I gave with Leah, then I could start her at 50%, right? But if you were arrested, you died, and I brought you back, you're getting 100%. Work my way backwards as quickly as possible. Does that make more sense?
Yes, thank you.
Like I said, we're going to get into this a lot more next week, Karen, when we talk about the individual modes and what you can set. There's a bunch of rules that you have to follow for the boards. And this is the stuff that all of you guys are working, are going to get hung up on because you're going to see a whole bunch of different crap at the hospital. That the rules are very specifically for the boards. Now, so far as getting them on as little as oxygen as possible, that is a universal situation. It's not just because of the boards versus the hospital. That is one thing that we do. We really try to wean down people's FiO2 as quickly as possible for those reasons we just discussed. So that is one of the things that's actually true. But you may take somebody who was, maybe on a cannula, and then they went to an airvo, and then they went to a BiPAP, and now they're vented. So as you continue to escalate, you may have to keep going up and up and up. Okay? Questions about that? Okay. So PEEP is defined as the pressure left in the lungs at the end of exhalation. Everybody has a certain amount of PEEP in your lungs. If you didn't, every time you exhale, your alveoli would just collapse. So when we put somebody on a mechanical ventilator, we're doing so because they've in effect lost their PEEP, right? They're atelectatic. They have some issues happening where they're not doing well. I need to give the PEEP back, okay? So we typically start off with a PEEP of around 5 centimeters of water. You can use between 2 and 6, and we're gonna cover this next week, okay? So PEEP is important. Why do we want it? We want to keep the alveoli open in an aerated state. Okay. Are there contraindications to PEEP therapy? Not to PEEP therapy as much as excessive PEEP. Okay, I don't want to give a whole bunch of PEEP because I can hurt the patient. The more pressure I put inside Alexa's chest, the less cardiac output she's going to have, more hemodynamic complications. So don't scribble all that down. We're going to get to this as we talk about issues. We have a whole lecture coming up on complications, but that's one of the things you have to worry about, is when you have too much pressure trapped inside someone's chest, it decreases venous return, cardiac output takes it down, they become hemodynamically unstable. Therapeutic PEEP as defined as 10 centimeters of water or more. So that's not that much, right? If I'm trying to give you back your 5 you're supposed to have, if I just add 5 more, that's in effect therapeutic PEEP. And I'm actually treating you with PEEP. Okay? Therapeutic PEEP occurs at 10 centimeters of water or more.
Can you explain again why it's called therapeutic?
Just because it means that this therapy is active, we're doing it on purpose to fix something.
So is it considered about anything above 5 therapeutic?
Actually, the boards look at 10, which is silly. I mean, I understand your point, but from a board perspective, it's 10 or more is therapeutic PEEP. Okay? Now, another thing that the boards talk about is that it doesn't matter how much PEEP you use for a board exam question. You can go up to 30. You can go up to 40. Nobody cares unless you start to show hemodynamic compromise. Okay? In other words, your blood pressure tanks. Cardiac output goes bad. You blow a pneumo. Okay? Now, contraindication perspective, if you have an untreated pneumo, that is a contraindication, right? If I have bleeding or pulmonary hemorrhage, I really don't want a lot of extra stretched out alveoli in there. It's going to cause a mess. So there are some contraindications, but you have to use it because of the disease states that are happening.
And you said 10 or more.
Yeah. 10 or more is therapeutic. Okay? Now, again, PEEP and CPAP and EPAP are all the same thing. Different devices, same animal. Okay? They're all cousins who work on the same landscaping crew. They all do yard work. They all do the same stuff. Okay? Questions so far? Okay? We're almost done. So sensitivity is what the ventilator will sense the person doing in order to cycle the breath on, right? We talked about this last time. You have a flow or a pressure sensitivity that you can set, okay? You want to make it easy for the patient to cycle, but without it auto-cycling, okay? Because you will see, and if you haven't already seen vents that are auto-cycling due to water in the tubing, for example, we put patients on those wound beds. They're called the sand beds, and they kind of jiggle, and sometimes that'll cause the vent to auto-cycle. And the vent's just breath, 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 because the water's in there going tick, 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 causes a mess. Okay, so what is going to give me the easiest chance for my patient to take a breath, to get that breath to cycle on? So cycling variable, what turns the breath on. Okay. We have 2 types, pressure and flow. And you'll get to play with this too to see how easy or hard it is on each other to make the breath take off. Okay? Now, going back to our friend compliance, remember our compliance buddy? I'm keeping this on, so I'm pretty sure. Space here. Okay. So a peak pressure is the highest pressure at the end of inspiration. So whatever the maximum pressure was registers as a peak pressure, which is PIP, or old farts like me actually called the peak pressure. Okay? That's the maximum pressure in the system during inspiration. So depending on how we're ventilating, whether it's volume or pressure driven, it'll be managed by the vent or it'll be capped by the vent, right? Pressure control, I have a set pressure. The plateau is my pause time. Plateau pressure is really a reference of alveolar pressure, so write that down. Plateau references alveolar pressure, which is super huge in COVID, okay? I showed you real quickly, you're gonna see this tomorrow, our graphics packages show us some cool stuff. Okay, so a plateau or a pause time is a very short hold that I have the patient do as they're exhaling. So as they go to exhale, there's actually a button that says expiratory pause. Okay, you do that hold briefly, you're gonna see the graphics do something like this. I'm a terrible artist, as you guys know. And in fact, it typically is a little bit longer than that. Okay, once that pause happens, a plateau number will be generated. That means we've paused during exhalation long enough to back pressure the doors open, and I'm measuring the pressure that's inside the alveolar units at that moment. Does that make sense? Okay. So plateau pressures that are increasing are not good, because that means the pressure at the alveolar level is worse. Now, old school, we were taught peak pressure should always exceed the plateau. But I'm going to tell you something, guys. These COVID patients, I've seen many a plateau higher than the peak, which is scary, because that means the pressure inside the alveolus is higher than the maximum system breath-generating pressure. That's why we're popping pneumos. Okay? Shouldn't be that way, but it is happening like that. So we're going to talk about this more later, but if you cannot get the machine to do a plateau, it's probably because the person's breathing too fast. Because you have to be able to pause that exhalation, and if they're tacking away, they're hypnic, it may or may not work for you. Okay. Now, I'm going to show you this tomorrow, but the servo defaults with a pause. So you get this on every single breath. You also get a consistent plateau reading. Now that's wonderful, unless you're trying to breathe on it. And then I'm making you go.
And the servo does that for every breath?
It does that for every breath in volume control mode. Yeah, volume control. So my point is get rid of it. If it'll automatically default to it, you don't want it unless the person is out of it and they just came out of a long surgery, because it's beneficial to help recruit alveoli. But if you are trying to breathe like that, you would hate it. Because like every breath you take in, try to blow out and you have to pause yourself. So in, out, and there's a pause every single breath. You'll go nuts. It's horrible for the patients. They absolutely hate it. So Dr. O is a big fan of leaving the pause in because he's a little bit old school. We did that a lot. You're not going to find current people today, especially with COVID, enjoying that. Okay, but if they're out of it, newly out of surgery, the plateau pause can be perfect for you to actually help recruit alveoli. That's what it's for. Okay? Plateau time, plateau pressure. So the time I spent here is the timing mechanism, but you're going to actually get a plateau pressure reading, and that's what we want. Okay? So if I put a pause, either on inspiration or expiration with maneuvers that I can do with the vent, I change I time and E time. So think about that. Okay, if I'm making you hold while you're breathing in, I lengthen your I time. If I make you hold while you're breathing out, I lengthen your E time. So again, not comfortable if somebody's really wanting to do their own thing. Is that clear? Yeah? Still good?
So the pressure control mode would be more ideal?
Yes. Yeah. I think you're going to find when you breathe on the vents that pressure control is just nicer. It's just a nicer mode of mandatory ventilation. Because we have lots of spontaneous modes. Okay, max MVV, where you're targeting targeting minute volume, is one of those modes. But if I'm guaranteeing you to have a certain minute ventilation, am I really weaning you? Right? That's one of the things I have to think about. We're going to get to that. Okay, so you guys have done compliance calculations before. right? So you remember simply, there's a bunch of formulas for it. Compliance, volume over pressure. Okay, static compliance is tidal volume in liters again, divided by plateau minus peak pressure. And dynamic compliance is tidal volume in liters divided by peak minus your peak. These should all be on your boobies. Okay. Now, because we're talking about mechanical ventilation now, we have to add in one more wrench. Okay, we need to talk about something called the tubing factor. Okay, the tubing factor helps me account for lost volume because of the stretchability of the circuit. Okay, so lost volume has to do with the stretchability of the circuit. Now, from a board perspective or a class perspective, you don't ever have to worry about doing this extra piece unless you see a reference to the tubing factor. Okay. So here is the cheat sheet on how you do lost volume. So I'm going to explain it now, but you'll forget by the time you start working on these.
What is the dynamic one there?
Dynamic is tidal volume in liters divided by your peak minus your peak. So these are in liters, these are in centimeters of water. So when you list it, you keep all the units. You can't get rid of anything. So in old school days, I used to have to calculate out the lost volume for the tubing before we put the ventilator up. Okay. We did that by getting compliance calculations. So we did 3 maneuvers where you did a volume over pressure calculation, and you would run a very small volume through your circuit. So maybe like 25 mLs of volume, something small. And then you would cap it and see what your pressures were in, because that would show you what the stretchability was of the circuit. I'm not going to make you go that far. What I'm going to do is give you the tubing factor, which would have been determined by that maneuver I just talked about. And the key to this is that you have to remember, I take the tubing factor and I multiply it by either the plateau or the peak pressure before I put it in the equation. So I have to find the lost volume. Okay, so this is what that paper I just handed you explains. So I have a patient who's got a 600 ml tidal volume. The plateau pressure is 40. He's on a PEEP of 10, and I have a tubing factor. I'm looking for static compliance. Let's work through that. Okay. See, stat, plat. That's how you remember. Stat, plat. That'll keep them straight in your mind. Okay. Now, this nasty little thing called tubing factor, I have to figure it out. Okay, so what I'm going to do before I do anything else, I'm going to take my exhale tidal line, which is 600. I have to find the lost volume. Okay, so what is 600 times 2.5?
What did you write? EXH?
Exhale tidal line, which is this.
Okay.
Okay. Hang on a second. I'm having a brain fart. Hold on a second. Oh, that's what I'm doing stupidly. Never mind. My apologies. That's what's wrong. So because I'm doing the static compliance formula, I need to take the plateau is what I'm gonna use as my factor. I take the tubing factor that I was given, I have to multiply it by plateau. Now, if I was doing the dynamic calculation, I would multiply it by the peak pressure, okay? I get 100 mLs of lost volume. So this is saying that out of my 600, about 100 of it is getting lost in the stretch of the circuit, okay? Now, new ventilators compensate for this. So we don't have to do this math anymore, but every once in a while the board will make you do this as a calculation, okay? So, the trick though is, once I found this, I have to actually take it from here before I put it in the formula. I'm gonna get an erroneous compliance, okay? So, I take what I just learned, is my tidal volume minus the lost volume divided by the plateau minus the peak. So I take my 600 that I had to start with minus the 100 I lost. Might be 10. Okay, so I'm getting roughly 16.7. You can round that up to 17 milliliters per centimeter of water as a static compliance. So this is more accurate than if I was not accounting for lost volume. Does that make sense? That's what's on formula 2, going down on your paper. Okay? That's why I typed it out, because it's too hard. It was too hard to explain to the last group on the computer, so I had to type it out so they'd be able to do it. So like I said, if you want to round that up to 17 milliliters per centimeter of water, that's completely fine. So static compliance and plateau pressures are related, right? If this is good, then it would go to prove I have probably a pretty good static compliance. Okay, stat plan. Okay, with me?
This might take some going over.
Well, we have practice. You're gonna have practice problems, so yeah. This is an awful lot of math, only part of which you've had before, so I don't expect y'all to get it perfectly clear today. You're gonna have a math packet to practice, and then we're gonna work on it. So every lab that you have, you're gonna have physical stations to work through with the vents themselves, but while you're not doing that, you're gonna have math to practice. Just so we keep doing it over and over again, okay? We good? Can I reset? Brian, you good? Okay. So it's been a minute since I did this. I had the wrong piece in there. I was like, this makes no sense. You can't have 1,500 mLs of lost volume, which is where I was going before. I'm like, that's more than the whole tidal volume. Okay. So do dynamic compliance. And this time, I'm going to use this formula, but I have to multiply my compressible volume as 3 mLs times the peak pressure that I'm given. Okay? So give it a try, see what you get.
Can you say that last part again, please?
Yeah, so this time, because I'm doing a different formula, I kind of want to write it out this way, it's even better probably. Okay, but I have to find this first. Okay, so I take the compressible factor, let's see, where'd it go? There we go. My compressible factor is 3. Times my peak pressure, there you go, that's in the formula, right? So I have to find my peak pressure, which is 25. So when I find out how much I lost, I need to put it back in here, okay? And I wrote it out. So tidal volume minus lost volume is really how whenever you have this factor, you need to write it like this, so you won't forget to take away the lost volume, okay?
Thank you.
So if you do the rest of it, you get 400 minus my peak with 25, minus 5, which works out to what is that, Roger? Really hate that I can't do that in my head. It's very disappointing. Yeah, 20. Okay. Does that make sense to everyone? No? Okay. So what I have to do first is I have to find the loss volume. Okay, so I took the compressible factor that I have, and because I'm doing the dynamic compliance, I multiply it by the peak. If I was doing the static compliance, I would multiply it by the plat. Okay? And then get what I need to get. So I've lost, in this case, only 75 mLs. I subtract it from the tidal volume that I was given, which is 475, gives me a tidal volume of 400, divided by my peak minus the peak, which gives me 20. Okay?
So it's pretty much like the static compliance are just different variables?
Absolutely, it's exactly like that. So I have to, so I said, if you write it this way, it might help you. Anytime you see a compressible factor, write it this way, because this is really what the top of the equation is. Okay? So you would do this first, then do this, then finish it. Make sense? Like I said, you're going to get a lot of practice at this. So because it's dynamic compliance, I'm using the peak pressure. If it was static compliance, I would use the plateau. Okay? Huh?
Peak inspiratory
Yep.
pressure.
Precisely. Okay? We have two more we're going to talk about real quickly, and then you're going to go on break, and then we'll come to some math. Okay? Alrighty. And I mean, you might have had both of these before. I can't remember. I think I talked about them. So again, the only time you have to worry about loss volume is if you have a compressible factor listed in the problem. Otherwise, you do it just the traditional way, as you've always done static and dynamic compliance. So here's another example. I won't go through it again, but most tubing factors are between 2 and 3 centimeters of water. That's how the new circuits are built. If you were going to do it by yourself, you could do it old school math. I'm not going to be asking you to find the compressible factor. I just want you to be able to do lost volume in your proper compliance calculation. Is that clear? Make sense? Okay.
Would that be how it is on boards as well, that they just have us find the...
Yes.
Okay.
Yes, but Dr. O likes to take it a step further, so when you get to him, he may go all the way back to the way beginning. I'm not going to. I just want you to be able to figure out what the loss volume is and subtract it from the tidal volume before you do your compliance calculations. If you can do that, you're going to be fine. Okay, so why do we care about this? Because all of the new ventilators account for it, which is really nice. When you hook one up, and if you've cleaned one yet, it always says to you, do you want to compensate for lost volume or compressible volume? And you just say yes, and it does all of that awful math for you. You don't have to do any of that stuff, okay? And that's what this stuff is talking about. Okay, so exhale tidal volume minus compressible volume. Another word for compressible volume is lost volume. So if you like lost better, I like lost better. This is how the book has it. So whether it's dynamic or static, we're just taking what we had minus what we lost divided by the rest of the compliance calculation, okay? That make sense? Any questions about that? Okay. Airway resistance. Resistance is obstruction to flow. And there's lots of things that bother that. How thick a gas is, length of the airway, right? You guys already know that if you have a trach, you have less resistance than if you have an endotracheal tube. Diameter of the airway. Who has seen a poor patient breathing through a size 6 straw when they're a 6.5-foot guy and they really want an 8? Seen that yet? It's horrible. It's like trying to suck through a little pinky when you could be using your thumb. Okay. Diameter of airway means something, clinical factors, and resistance. I'm going to get the normal resistance and calculations from Dr. Owe. You guys are on break. I want to make sure I'm using the ones that he's currently using, just so we're on the same page. So I'll get those from him and I'll let you know in just a little bit. We have a formula for it. You've done this before. Peak pressure minus plateau divided by flow, once again in liters per second. So you may have to convert that if it's given to you in liters per minute. Okay. We've done this a lot. Anybody have any questions about it? Okay. One last piece of calculations today. We're going to talk about the mean airway pressure. And this is the average pressure throughout the breath timing cycle. And PEEP really has an effect on mean airway pressure. We like to increase mean airway pressure to improve oxygenation. And that is why PEEP has to do with it, right? If I up the PEEP, I get better mean airway pressure, better oxygenation. Does that make sense? Okay, all better, better, better. The formula for it, I time times the peak pressure plus E time times the PEEP divided by total cycle time. The answers are in centimeters of water per liter per second. So we keep everything. Okay. Now, you may have some of this, you may have to find it. You may have to use your calculations over here to find some of this stuff. It may give you part of the puzzle. It might give you all the pieces and you just plug it in. Okay? So, for your quiz Thursday, right? Thursday. I don't know what day it is. It's a good thing too, because I had Miss Polly helping out with either staying with you guys while you take your quiz or taking my mom to her shot, because it's happening, I might overlap by half an hour. I'd have had her doing it tomorrow, I need to go tell her. I'm gonna let you use the Whoopie with your formulas. Okay, so any formula for this first quiz, this whole content of this PowerPoint, get on a 3x5 note card, bring it in. Do not use any normal values, okay? But I'm gonna let you use a Whoopie because it's a lot of content and it's coming at you like, boom, really fast, okay? So you can bring a Whoopie, 1 3x5 card, front to back. I will check it, okay? Any questions?
That was my question.
Yeah? Yeah, please, baby Jesus, can I have a Whoopie? Well, we're just starting, so as we get closer, I'll start, making you do more, but when you're doing